Realize.
So, good morning, dear delegates and respected faculty. On behalf of IIP Delhi, I welcome all of you and wish you all a happy Diwali. Let's have a festival of lights and happiness. I request Dr. Maninder, coordinator for this program, to please continue the proceedings.
Hi everyone. With the from Delhi IIP, hi to everybody. So it's pre-Diwali. I understand the attendance is a bit short, and but we'll carry on with the program. So we have our expert with us, Dr. Lokesh SAINI. He is a pediatric neurologist. He's trained in AIMS Delhi, then further training at PGI Chandigarh. Then he shifted to AIMS Jodhpur, and now he is associate professor at AIMS Jodhpur, and he has started the AIMS DMP neurology course there. So congratulations to Lokesh for starting the DMP neuro course. I think so. It's the first one in Rajasthan. So congrats to you. And we have been friends for a long time, Lokesh. So he has lots and lots of papers, research, articles, and he's very much approachable. That is also a very good thing. Whenever we are in trouble, we contact him, and he gives a very practical answer, not a textbook answer. So with that, we welcome Dr. Lokesh here. And then we have moderators, the intensivist, because now neuro and neuro ICU are actually co-dependent on each other. And we have none other than Dr. Namit Jairaj sir. He is the head of pediatric ICU and pediatric pulmonology at Apollo Hospital, Sarita Vihar. Sir is trained abroad in PICU, and then he started the PICU at Apollo. And he's a mentor of mentors. He has many students in PICU. He's also one of the leaders in the Indian College of Pediatrics, IIP, and he's been the president of Delhi chapter IIP. And with that, I would like to invite Namit sir, and please ask all the difficult questions to Lokesh, because sometimes there's a conflict between an ICU person and a neurologist, and we don't, it's okay for the brain to fight, but not the intensivist neurologist. And we have a very young colleague with us, Dr. Dhirendra Pratap. He's trained in RML Kalavati and then at Medanta, and he's presently at Amrita Hospital, Faridabad. He's a person who is very technologically dependent. He loves technology, HFOV, ECMO, immunomodulation, all the hi-fi drugs that you can think of, anakinra, rituximab. So we have a right mixture of people for this very important topic, status epilepticus and the seizures in PICU. So with that, I invite Dr. Lokesh to please start the session.
Thank you, sir. So I will just correct that I've done my MD from PGI, then did my DM from AIMS Delhi, and then went to PGI Chandigarh as faculty for 5 years. And from last 5 years, I'm at AIMS Jodhpur. So
neurologists can never be wrong.
Neurology training was done at AIMS Delhi.
AIMS Delhi. Okay.
Yes.
Okay. So you are the co-host, I think so. Yes, you're.
It's visible, sir?
Yes. You can make
Please
it.
make it full screen.
Full screen.
Yes. Is it okay now?
Yeah, please carry on.
Okay. So good morning, everyone. Good morning, PICU, e-PICU forum, for giving me this opportunity to interact with the intensivist. So I personally feel that status epilepticus should be a topic primarily it is dealt by intensivist emergency physicians, but we only give inputs in between if they are they ask for, but it is primarily a job of intensivist or emergency physician primarily, because they come to emergency. Status means an emergency. They come to emergency, manage there primarily, and then shifted to PICU, most of them. if they are being shifted to ward after settling in emergency, that is also because of the care given by emergency people at emergency. So we have limited role, but sometimes very important. So I'll start with this definition of status epilepticus, which was given by ILA Task Force 2015. So status epilepticus is a condition resulting either from the failure of the mechanisms responsible for seizure termination or from initiation of mechanisms which lead to abnormally prolonged seizure. So that they are defined as of time point T1. So what they mean is that seizure termination is difficult beyond this point. And what with this time point T1 we will be learning in the next few slides. And another way of defining it is a condition that can have long-term consequences after time point T2, including neuronal death, neuronal injury, alteration of neuronal networks, depending on the type and duration of seizures. So this is again the concept of time point T2, where irreversible injury can set in after this particular time. So there is time point T1 and there is time point T2. So this concept has to be learned in status epilepticus definition upfront. So time point 1 is, again I will retaliate here, that time point T1 is where there is chance of prolongation of seizure if it is not settled before this time point T1. And if time point T2 is, if it goes beyond, seizure goes beyond this point, it definitely there are chances of neuronal injury, which can be irreversible also. So I have also incorporated questions which were asked in the WhatsApp chat group in between my slides. So what are T1, T2? One of the question is this one. So for different type of seizures, it is defined differently, right? So for generalized convulsive seizures, so which everybody has learned, that is the severest form when by appearance. You can see when child is seizuring and having generalized tonic-clonic seizures, they will look in very bad shape. So that is the most common seizures shown in movies also. Okay, so and sometimes that is the only seizure image is in most of the residents and even parents view, that okay, this is the seizure, nothing else other than this is seizure. So this is the seizure which is cannot be missed usually. So here you should learn that time point T1 is 5 minutes, okay, and time point T2 is 30 minutes for generalized convulsive seizures. Coming to focal seizures, which looks less severe by appearance only, time point T1 shifts to 10 minutes and time point T2 is 60 minutes. And third type is absence seizure status epilepticus. So now one will wonder that what is absence status epilepticus? So usually this type of seizures don't come in emergency. They come to us in OPD. They are already seizure patient or some syndromic patients like Angelman syndrome can have absence status epilepticus. Or if a child with juvenile myoclonic epilepsy, if you prescribe sodium channel blockers, they can go in absence seizure epilepticus. So they will have just blank look, unresponsive for hours together. Because it is so rare, there is no time point T2 defined for this absence status epilepticus, but usually time point T1 is more than 15 minutes. So what ILA task force recommends that treatment should be started at T1 itself. Okay, so if the time point T1 is already occurred, so mostly when GTCS children comes to our emergency, by the time they reach our emergency, if they are seizuring, we take it as a status epilepticus because it usually take more than 5 minutes. And status epilepticus should be controlled. So that is there because we don't want reversible neuronal damage. And you don't want to make them as our patients in follow-up. So you want to control this at definitely by this point T2. So what is the timeline of action? So you just understand this. So stage 1, early phase premonitory status epilepticus or impending status epilepticus, 5 to 10 minutes. Established status epilepticus, that is stage 2. So beyond 5 minutes or 10 minutes, depending on the type of seizure. Then refractory status epilepticus, usually one can label as it is around 30 to 60 minutes while managing these kids. And then finally, stage 4 is super refractory status epilepticus that continues despite treatment with anesthetics more than 24 hours. Now I will tell you one very important concept. So this stage 1, if you stop seizure somehow or by any means here itself, there are high chances the seizure will not prolong to goes or it will go to stage 4. That is why the concept of intranasal midazolam at home is, it has spread all over India or all over the world, you can say, since the inception of this simple, medication, which can be given at home itself. As everybody knows that early the seizure control, there are less chances it will go in status epilepticus. So if you give some drug as early as possible at home itself or while transit to hospital, there are very less chances that it will go to super refractory status epilepticus at least. So that is why one should always prescribe midazolam nasal spray to kids who are having epilepsy or they are prone to have seizures. So what is the pathophysiology? I will not discuss this in detail, but just understand that as the stages we have understood from premonitory SE to super refractory SE. So it starts with protein phosphorylation or neurotransmitter release, then receptors, GABA, there should be for seizure prolongation or seizure continuation, that inhibitory transmitter will decrease and excitatory transmitter will increase. That is why the drugs also acts by these mechanisms, like we can use ketamine later on, GABA mimetics. So, so GABA is decreasing and excitatory NMDA receptors are increasing, AMPA receptor also. So like parampenal, it is also increasing. You want to decrease them. So that is why we can use parampenal in some pathway later on. Then neuropeptide expressions, this is also excitatory substance P. And later on, finally, when it goes to super refractory status epilepticus, it goes to the level of gene expression. There is a change in gene expression, DNA methylation, and then regulation of microRNA also. So at the genetic level, changes ensues. So what is the first line and management? So this is known by you people better than me. Stabilization, that is the rule for any kind of emergency. So 0 to 5 minutes, what will be done as soon as the child comes to you? This is, I am sure that you must be more aware than me, everybody in this attendance. And first line, everybody must be aware that we give benzodiazepine. Now, benzodiazepine, there are 2-3 benzodiazepine easily available, but most commonly, if available, lorazepam should be preferred because of short mechanism of action and there is less chances of respiratory depression also. So 0.1 mg per kg may repeat once after 5 to 10 minutes and midazolam 0.2 mg per kg. And if you want to give diazepam, you can also give diazepam if both of the drugs are not available. But something should be given as early as possible. Even if you don't IVSS, give midazolam nasal spray or oral midazolam. Something should be given as early as possible. So alternatives if no IV. This was one of the question in the yesterday's chat box. So IM midazolam can be given 0.2 mg per kg. Buccal intranasal midazolam. Then rectal diazepam. And what should be taken care of is that you should not exceed 2 doses within a span of 10 to 15 minutes. Now, any resident want to answer, they can raise hand or they can type in the chat box that why should we not use more than 2 doses? Okay, so first line drug is always benzodiazepine, which So you can use different routes, different preparations are available, midazolam, lorazepam, diazepam. Whatever is available, something should be given. Definitely lorazepam is better because of its short action. Okay. And always remember the ceiling dose. That is also very important. So this I want to highlight, because many a times we end up giving doses which are not, even ceiling dose, it crosses ceiling dose, and sometimes respiratory depression occurs in emergency itself or outside hospitals, and they may go in respiratory failure very early. So remember these doses. Midazolam 10 mg is the ceiling dose, lorazepam 4 mg, and diazepam 5 mg. Okay. So what does the evidence say? First line pre-hospital medication. So we'll see these two RCTs, and you can clearly see that most of the benzodiazepines are equally efficacious. IM midazolam, IM IV lorazepam, IM midazolam, IV lorazepam. So at least these two RCTs which are published in NEGM and epilepsy, they clearly say that you can use IM midazolam also. If IV is not available or IVSS is not available, it is equally efficacious as IV lorazepam. So no, no excuses if you don't have IVSS. You have to manage the status as early as possible. Okay, there are other RCTs also. They will also say the same thing, most of them. Okay, so IM midazolam, IV lorazepam, again, they found equally efficacious in meta-analysis of 16 RCTs. Then non-IV midazolam, they found more better than IV or rectal diazepam. So only thing is diazepam is little less efficacious than lorazepam or midazolam. If available, it should be used lorazepam or midazolam. Preferred to diazepam. So IM midazolam, IV lorazepam, IV diazepam. This is the evidence says. But practically, we can use IV midazolam, IV lorazepam, and if it is not available, anything else. So this is the evidence which is there already on this first line drug. If any of these three are not available, what should be done? You can go to intranasal, buccal, IV midazolam, IM, or rectal diazepam. They all can be the options. So no excuse if benzodiazepine SS or formulation is not available. You have to use in one or other way. So if the child continues to seize despite 2 doses of benzodiazepine, what should be the next choice? So second line drug. So coming to second line drug, when to choose, what to choose. So remember, if you are using levetiracetam, which is the preferred now drugs for the safety purposes nowadays in many of the centers, but always use at least 40 mg loading, or you can use up to 60 mg loading also. 20 mg loading, which we were using before, it is definitely less efficacious than the other available drugs like fosfenitoin or valproate. So remember the dose of levetiracetam. If you are loading with levetiracetam, at least 40. Then fosfenitoin 20, valproate 20 to 40 you can load, and phenobarbital 20 mg per kg. These are the 4 available and commonly used drugs in emergency setups. Okay, and many of the centers still use phenytoin, especially peripheral health centers. But what we see, and even I have just published an original article, there are a lot of phenytoin toxicity happening because of not documented phenytoin given everywhere before reaching to tertiary care centers. So beware of, if possible, don't use phenytoin. If possible, better to use levetiracetam or valproate or fosfenitoin if it is available. So why levetiracetam? Because it is a commonly used. So clearly the trials say that it is, you can see levetiracetam not superior, but seizure termination higher and faster. But dose, I already told you, it has to be 40 or 60. not 20. Definitely 20 is less efficacious. Against levetiracetam, not superior, but equally, almost equally efficacious than this phenytoin and phenobarbital or valproate. So clearly these landmark trials which are published in Lancet, they clearly says that levetiracetam can be used, but at the 40 to 60 mg per kg doses. And ESET trial, what does it say? It is published in NEJM, which has, they have tried phosphonitoin, valproate and levetiracetam. No difference in safety, efficacy of phosphonitoin, valproate and levetiracetam. So this is, you can say, this is the last word, that there is no difference in safety and efficacy of all these three drugs. So anything can be given, but doses has to be remembered. So before levetiracetam came in picture, there are two commonly used drugs, phenytoin and valproate. So obviously, we know that phenytoin, phenobarbital are the stronger antiepileptics or more efficacious antiepileptics, but the safety profile is very low. That is why valproate has been tried in past. Okay. But also, you should be learning that they were also found to be, almost there is no difference in their efficacy, but safety profile of valproate was better. Okay, so if you're coming to individual drugs, as I told you, phenobarbital is the most efficacious anti-epileptic we know, but most side effect profile is also with the phenobarbital only. So that has to be remembered, that if you are using phenobarbital, there is high chances of adverse events with the use of phenobarbital. But in neonates, it is different. As we all know that their metabolism is different and they metabolize phenobarbital faster. There are less chances of side effects. That is why it is still the most, it is the first line treatment in neonatal status epilepticus or neonatal seizures. So second line drugs, what is the consensus? So levetiracetam, no conclusive evidence that it is superior. First thing you should know, it is not superior, but it is almost same efficacy. And there is ease of administration and side effect profile is less preferable. Phenobarbital and valproate, overall no difference. Both are safe and effective. Both are efficacious than phenytoin. Valproate has less cardiorespiratory depression, but hepatotoxic. So if you don't know the etiology, or if you suspect that it can be a metabolic etiology, try avoid valproate in that setting. If you know the setting, if you don't know, obviously you cannot know that the child has underlying. But if there is already a liver dysfunction is there, try to avoid valproate. Phenytoin overall rank seems to be decreased because of the side effect profile. Phosphenytoin you can use as efficacious as valproate and levetiracetam, but remember that it is a prodrug. It takes time to act. There is a time onset of action is there. So immediately it will not act. So again, this child continues to seize despite 2 doses of benzodiazepine and 1 second line AED, which was given levetiracetam for 60 mg per kg per day. What should be the next choice? So now here, so you remember 2 doses of benzodiazepine, 1 second line drug. Here, if the child continues to seize, we label this as refractory status epilepticus. So what is the evidence, or what do we do usually? So if seizure persists despite benzodiazepine or 1 anti-seizure drug, choose second line ASM, choose based on which drug is not used prior. So whatever is not used prior, levetiracetam, brivaracetam, lacosamide, phenobarbital. So this is preferred in non-ventilated patients. Okay. Or early consideration of intrathecal dexa or midazolam infusion if EEG available and in ventilated patients. So I have used intrathecal dexa here, or if you can, most of the centers midazolam infusion is still going on. But if the etiology is fires, or if you don't know the etiology, there are less chances of infectious etiology. It is a very good drug, which actually, at least I have experienced 15 children I have used on till now, and all 15 were managed beautifully. Outcomes were very good. Some of them are absolutely normal also after post-discharge, despite they went on to super refractory status epilepticus. But this is one of the drugs which we can think of early. But midazolam infusion, as we all know that most of the centers we use midazolam infusion at this stage. So second line, what is next? If one drug from second line medication is not successful in controlling seizure, 2 points you should always consider that within first hour of seizure, no evidence that anesthetic agent is traditional second line medication. So this point should be considered that if the child is still in the first hour, there is no evidence that anesthetic agent will be better than any second line medication. So try other medication before going on to midazolam or phenobarbital or any like intrathecal dexa. So try one more drug. Anesthetic agents, there is high chances of cardiorespiratory depression and hypotension. Usually not high chances, it is always invariably. That is why ICU setting is there. Obviously, you can go here with anesthetic agents ahead. So what is the recommendation? That second line medication be administered if the seizure persists for 5 minutes after the first second line medication has been completely administered. So this is the recommendation. So if after levetiracetam of 60 mg per kg, seizure is persisting for completion of 5 minutes, then you can use one more drug. And what is the mortality? Usually what literature says, once the child goes in refractory status epilepticus, it ranges from 16 to 44%. That is why you have to be very quick and be ready with the thought process, what is to be given. You cannot decide there on at the time of management. You have to be, should be protocols in the emergency. What should be done next? So coming to super refractory status epilepticus, if it is not controlled beyond this point, so seizure persist or recur more than 24 hours despite anesthetic therapy. If you have already used an anesthetic agent, but seizure is persisting, it is ongoing for 24 hours, or if you have, or it has recurred, it has stopped, but it has reoccurred while if you are tapering or you're continuing on the same dose and it has reoccurred. That is also super refractory status epilepticus. So what you should do here, if seizures persist, additional oral ASM can be added. Lacosamide, perampanel for focal seizures, especially for focal seizures, perampanel or lacosamide is very good options. Or topiramate oral loading, which we give, and clobazam can be used here. Then you can go for thiopental or pentobarbital coma, bolus followed by the maintenance dose, then ketamine infusion. So these are three options which you can have here: 1 to 2 mg per kg and then 1 to 5 mg per kg per hour. Especially if your admitting possibilities fires or NORS, and if already have used DEXA. If you have not used DEXA here, you can actually use DEXA, which has very good results in fires and NORS, intrathecal dexamethasone. Third line, so midazolam, ketamine, thiopentone, propofol, pentobarbital infusions. Heterogeneity of choices among treating centers. As we all know, private centers, every center have their own protocol. I'm sure Dr. Maninder, Dr. Namit sir, and most of the centers will use their favorite or their whatever they have experience with. There is no set protocol what is to be done among these drugs. And concurrent use of any other medication affecting CNS. So this is a mixed bag where one uses drugs based on their experiences, but among these options only. These are 5-6 options. I have already also added intrathecal dexamethasone. If you have not used before in the second line option, you can use in third line. So what does the evidence say? Published evidence, literature, systematic review published in epilepsy on pentobarbital versus propofol versus midazolam infusion. So they found pentobarbital better. Then this is done by our own Singhi sir, that RCT open labeled 40 children with RSE, midazolam versus diazepam infusion. equally effective midazolam has higher recurrence and mortality. So they found this infusion equally effective, but midazolam has higher recurrence and mortality. So what is the midazolam infusion protocol? So initial bolus, give 0.5 mg per kg, start continuous infusion, start at 2 mics per kg per minute, and then you can increase gradually, increase infusion to 4, then increase by 4 microgram per kg per minute. And by evidence, you can go up to 36, but usually most of the centers go till 18 or 20. Okay, if that is not seizures are not getting controlled beyond that, beyond 18 or 20, usually there are less chances that it will get controlled after that. So maximum recommended dose of IV midazolam infusion is, so you should learn that it's not about dose, it is EEG burst suppression, which is our target should be achieved. So usually we can go up to 20, but what literature say we can go beyond that also, as I've already showed in the last slide, till 36 mics per kg per minute. But if it is not working beyond 20, there are less chances that it will work till 36 mics per kg per minute. And what is the role of immunotherapy? So it depends on the etiology. If you're strongly suspecting that it can be immune-mediated, especially like NORS, fires, ITES related status epilepticus, infection-triggered encephalopathy syndrome, which are now in the trending, acute necrotizing encephalopathy, AESD. So if you are knowing the diagnosis and they are having status epilepticus, you bring these drugs early. And if you're suspecting that remotely also that you have tried everything, but they can be autoimmune or immune related status epilepticus, these are the options. IV methylprednisolone for 5 days. Then IVIG for demyelinating autoimmune, ketogenic diet can be tried, plasma exchange, and tocilizumab if you are having cytokine storm. So what we do in our practice, we also test cytokines very early, IL-6, TNF alpha. So if they are raised remarkably, we use these drugs if we don't find any evidence of infection in that particular child. Okay, so these are the commonly used immune drugs, which most of us will be knowing and must have used in different conditions. So to summarize, stabilization, then first benzodiazepine, second benzodiazepine. So here I will just ask question to residents if they want to type in the chat box that why only 2 doses of benzodiazepine, why not more than 2 doses usually given before using first line anti-epileptic drug.
So they cannot type in the chat box, so I'll answer. They have majority answered respiratory depression.
Okay. So I will discuss after I finish. So this is a protocol for fires, but the summary of this busy slide is that you can use early dexamethasone or early immunomodulators if you are suspecting fires, or even NORS. So these 2 entities, if you are suspecting strongly, MRI is clean, no infections are there. If you've ruled out them, early immunotherapy has very good outcome. So role of ASM and TBI, ICH. What should be given, if you should give regularly, even if they don't have seizure. So these are the guidelines. Early post-traumatic seizures within 7 days. Guideline, it is not routinely recommended. If severe TBI is there, GCS score of less than 8, ASM of choice is levetiracetam. So one thing is very clear in this recommendations is trauma-related seizures or tumor-related seizures. Levetiracetam is drug of choice. That is very clear. So levetiracetam should be given. If severe TBI, GCS less than 8, you can use levetiracetam. Prophylactic treatment does not prevent late seizures or post-traumatic epilepsy and doesn't improve functional outcomes. So its use is often limited to the immediate post-injury period. So what does we do? We start antiepileptics if there are immediate seizures, and by the 3 months post discharge, or if the child continues to be in hospital, we do a MRI to know if there is cortical injury. If there is cortical injury, we continue because there are high chances of seizures again in next 2-3 years. If there is no cortical injury in the child, that you can safely stop without doing any EEG also. If there is a cortical injury, continue antiepileptics for at least 2 years and do follow up with that EEG as if the child show breakthrough seizures, and or while stopping the anti-seizure medication at the end of 2 years. Role of 3% NaCl versus mannitol while managing status epilepticus. So 3% NaCl or mannitol can be used. Both of them. Choice depends on the hemodynamic status, renal function, osmolality. Hypertonic solution nowadays is preferred in ICU settings because of less side effect profile, but sodium monitoring should be done very stringently in these kids. And these two has to be used when you are having features of raised ICP along, or if there are high chances of raised ICP when status epilepticus is going on, if someone wants to use, but has to be used with caution. So coming to breakthrough seizures, this is the common query. Is this seizure a significant deviation of the child usual seizure pattern? So these are the questions you should be remembering. Does this patient have a history of more serious seizures such as status epilepticus or clusters of seizures? Is the patient sick or drug levels are low? If you have access to drug levels. So if this is any of this is there, answer is add drug. So you have to add drug. Single seizure, poor adherence, same dose restart. Drug levels low, optimize it. So this is very clear. If you have any of the 4, you add a drug. Single seizure is there or poor adherence history is there, same dose, you can restart. What is the ASM choice in liver failure? So what we use is levetiracetam. So one should remember levetiracetam on, if second line, if status is there with liver failure, lacosamide is one of the good option. After, if you have used benzodiazepine 2 doses, levetiracetam, and then lacosamide. These are the commonly used drugs when liver failure is coexisting with the status epilepticus. So with this, I end my talk, and I will be happy to answer questions or doubts of residents and panelists if they want to ask. Thank you.
Hi. Thank you, Dr. Lokesh. It was a very clear lecture. So we have many questions in the Q&A session. So I'll ask one by one with Namit sir also. Namit sir, first we'll take some comments from you. Anything that you want to say and comment and be critical about. We have neurologists, we can attack him.
No, I think it was a very good, concise and to the point summary of status epilepticus. I think it was a very good lecture. So a couple of points, if I might make. I think you mentioned that you would discuss the role of benzodiazepines and repeat doses. So I'll leave that part. I'll leave that for you as to why not to give too many doses of benzodiazepines if it is not working. So that is an important concept. And if benzodiazepine doses are not working, then we tend to skip the benzodiazepine infusion as a part of the SE protocol, and we jump onto other drugs earlier. So that is one comment I would like to make, and I'll leave that for Dr. Lokesh later as to why not to give more benzodiazepines if they're not working. Again, it depends on the setup where you are. I think he has emphasized strongly that the idea is to get seizure under control early. So if you are in a setup where you have intensive care backup, where respiratory depression can be managed, I think the priority is to get the seizures under control, even at the cost of respiratory depression, which you can manage. Because trying other drugs, trying to avoid respiratory depression and not getting seizure under control sometimes can be very difficult and tricky. Intrathecal DEXA we have used recently. It's something which has come up recently. I'm we sort of did a review, and we weren't very sure about how strong the evidence is right now of intrathecal DEXA. But again, yes, this is something new which is in the armamentarium available for intensivists and neurologists now. So those are the few comments, and maybe later on I can come back to you and ask you about when to ignore seizures. So we often have super refractory seizures, children seizing for weeks, months in the ICUs, and that is a very particular subset. And then we start choosing our seizures. We start choosing which seizure to treat and which not to treat, and trying to ignore some seizures, some subtle seizures or focal seizures or short bursts of seizures we tend to ignore. So that is probably a very specific question, and I would ask Dr. Lokesh to throw some light on it as to when we start thinking about not to treat a particular seizure or to start ignoring a few seizures. But yeah, I think it was very good talk, and I learned a lot. Thank you so much, Dr. Lokesh.
So, sir, about intrathecal DEXA, I will answer that there is no evidence existing, clear evidence. Maximum published data is of 6 patients together, case series of 6 patients. So we have around 13 patients, and we are almost have written that and it is going for publication. And where we reviewed all the published case reports also. There's usually case reports with intrathecal DEXA. So what we found is we divided in 3 groups our patients retrospectively, and like immune mediated pathology, which we found later on, or possible immune mediated like fires or NORS. And third is definitely not immune mediation, not likely. And we could see that wherever there is immune mediation plus possible immune mediation, results are excellent. And when there is there were 2 children with acute lymphoblastic leukemia, and they have gone into status epilepticus, where there also we have used as this intrathecal DEXA as last resort, but there we did not find any good result. Maybe so etiology also plays a part in this definitely this result. So another question, when to stop chasing seizures in ICU or emergency setting. So once they go in like this status, super refractory status, once we have already managed 24 hours, 48 hours, and like if we EEG monitoring is available and we are doing EEG monitoring, if they are not in the non-convulsive status epilepticus or EEG is very bad, like continuous seizuring, so that there is the need that we come down, or we don't need to increase anti-epileptics, because they also result in downfall of the patients. Because sometimes I see 20 ASMs or whatever available in the world is going on, but the child is continuously seizuring. So sometimes even this drug interaction will also worsen the child, and sometimes this is one of the reason for seizures. So try to cut down on the seizures beyond 72 hours, like chasing seizures beyond 72 hours. Once you have stabilized the child is hemodynamically stable, seizures, if they are not on the EEG, if they are just happening, but there is no hemodynamic instability, these are the usual parameters which we choose. But definitely beyond 72 hours, we have managed aggressively. I am sure that whatever is the underlying etiology, if you don't target that, the seizures will not stop. So that is the principle which we follow. If we think that structural pathology is there, so recently 4-month-old, we did epilepsy surgery for a hemimegalencephaly. Seizures were not stopping, so we were sure that it will not stop because they are firing continuously from one hemisphere, and so corpus callosotomy was done. The child was managed successfully, and we could discharge also. Now no seizures on follow-up also. But she has an underlying condition of hemimegalencephaly. Obviously, prognosis depends on that. Immune mediation is there. Immunotherapy can be hiked, not the anti-seizure medications, after 72 hours. So that is my principle, and that is what I have read also in the literature, that beyond certain point, we have to target the etiology, not the seizure.
Perfect. Perfect. So there are many questions in the chat box. Dhirendra, we'll ask you question later. We'll give you time later. So the first question was basically, what is the dose of intrathecal DEXA that you are giving? to
Sir, I
look
have a protocol which we made from the whatever case reports and case series has been published. So we give for 4 doses, 12 hour apart first, and then the repeat cycle if the child shows some response. So 0.15 mg per kg only we use, but intrathecally when we gradually hike the dose on the second, third, fourth dose. So, but initial dose is 0.15 mg per kg.
Okay, and the people are answering, few of them, that the 2 doses should not be given because it causes internalization of the benzodiazepine receptors, GABA receptors.
Yes, yes. So that is true. That is one of the main reason that receptors gets internalized, and whatever benzodiazepine you give, it will not work. So after 2 doses, so 94% or 95% receptors gets internalized. So only 5% receptors are there. That is why. So you want to increase the dose. You give it in an infusion sometimes to overcome this barrier. But usually after 2 doses, there is no use of giving any benzodiazepine.
Okay, now there are many specific questions coming in. So I'll go one by one from top to bottom because there are many questions.
Sir,
So if we give benzodiazepine first dose, should we have to wait for 5 minutes before giving the second dose? Over to Lokesh.
no, not for 5 minutes.
So when is the second dose recommended?
Second dose, if you have completed benzodiazepine and the child is continuously seizuring, maximum I wait for 2 minutes. But if you go by book or protocols, it is given 5 minutes, 10 minutes. That has never followed in emergencies.
Right.
5 minutes
I
you
think so.
wait.
Dharinder also agrees with that, right, Dharinder? We don't wait for 5 minutes. The child is seeking, I not just keep standing there, right?
Yes.
Okay,
So
so we'll
that is,
but
I always get surprised by reading these protocols, which is published and given in the even bigger journals. You wait for 2 minutes, 5 minutes, but I don't know how people wait when the child is seizuring. And that is something which I want to take opinion from the experts available in the panel.
I think so. Namit
What
sir
does
actually
they?
agreed. He told that if you have a backup, it's better to treat it aggressively. And sometimes people are scared that if you give 2 doses fast, the patient's breathing might stop. Though I feel it's wrong, it's a myth, because we have given many times and none has gone intubated. They will just get up within 2 or 3 minutes after you give it. They will go for respiratory depression. There will be a CO2 rise, but we don't need to treat it at the moment.
Yes.
But if there are ventilation facilities available, you don't worry about the respiratory depression.
Agreed, agreed, sir. Totally agreed. So next question is over to Lokesh and Dharinder again. Why not intranasal midazolam? Why all the studies are saying IM midazolam when we have intranasal midazolam in our ER formulary? It's very easy to give. IM is again painful. Lokesh, first over to you. Why not intranasal? In the chat box, everybody agreed that we have to give intranasal.
So, sir, I will tell you this is all about evidence. So studies are not being done. RCT form, if it is done, we all know that whatever is the gold standard treatment, we cannot divide the child of that. So if something is gold standard, like IV lorazepam or IM midazolam, already established, it is in the guidelines, we cannot put one arm that will not give IM midazolam in that arm or IV lorazepam in that arm. So that is the problem with generating evidence. If you do that, it will become unethical. If something happens, like you may find after 20 patients that all intranasal midazolam children are not responding or dying more or going into status more. So that can happen. So there are no published good literature or RCTs. That is the problem. This evidence is not there. But if offhand, like I'm telling, dexamethasone works, this will not have any value till I publish this.
Agreed. I agree with you, Lokesh. So I'm saying practically bedside. Is it okay for a pediatrician to give intranasal midazolam instead of IM midazolam in the ER setting?
Yes, it is definitely advisable. Definitely advisable.
Okay, so IM midazolam is preferred, but we can use intranasal midazolam.
But the
So
only thing is, if the child is in emergency,
in the
where
emergency.
easily IM or IV can be given. So that
Yes, it can be given.
so if then definitely that it has to be given, because evidence also says that it is, if it is given, if in OPD, even in like my OPD, I see around 150 patients a day, almost daily, and so 1 or 2 children will have seizures in that waiting period. So we have intranasal midazolam spray in our OPD, and we used to have every week at least 1 or 2 patients we use intranasal midazolam spray only.
I think that point is clear. I mean, an intravenous or intramuscular is a definitive therapy. Intranasal is still an assumptive therapy that you are giving intranasal and some of it is getting absorbed. While you're waiting for your IV or IM preparation to get ready, and if you have intranasal, please go ahead and give it. But after you have given, don't stop your process of giving a definitive therapy if the child is seizing in front of you. We cannot give an intranasal midazolam and then wait for it to work before we start looking for the IV dose.
Completely agree, sir.
So, Dhirendra, this question is to you. So, levetiracetam, you want to give 20, 20, 20 in next 3 hours, or you want to give 60 dose in the next 30 minutes?
We usually give 40 to 60 mg per kg in a state group. We don't give in
piecemeal giving
fast.
20, 20, 20 is a very obsolete phenomena. It should
Absolute,
not be done like that. Okay. And if after giving 2 doses of benzodiazepine and we have given a second line drug also over to Lokesh, we have given Levera 2 doses of benzodiazepine, another seizure happens. Should we keep on giving multiple doses of benzodiazepine for the breakthrough seizures or recurrent seizures?
No. So that is a continuation of the same, like, status epilepticus. Already you have tried. So go for the other drug. Because already I've told that this question, that if you have already used 2 doses of benzodiazepine, levetiracetam at maximum dose, so you have to add another drug here.
So now this question is, suppose somebody has given a Levera of 40 and seizure is not getting controlled. Should he give another 20 of Levera to make it 60? A very specific question. Or should he go to valproate of phenytoin?
So because 40 to 60, that is what already evidence is also there, and we have also used 40. But if 40 it is not working, there is definitely no use of giving 20 add-on in levetiracetam. So either give 40 if you want to, if you are not sure if that this is not working or it is partially worked, but not 20 again.
So this is over to Namit, sir. Levera should be given as a bolus over 10 minutes, 30 minutes, 60 minutes.
I don't really know how fast it can be given, but I think we give Levera over 15, 20 minutes.
Yes.
I don't think we prolong it to an hour. But I don't really know in the textbook what is written.
No, it is given as early as possible. Like there is no protocol to you have to be wait for 1 hour or something. It's like phenytoin. Phenytoin you have to give slow for certain there's a rate to which you can give.
Correct. So one more question. In refractory status, we discussed a lot about intrathecal DEXA, and you have answered also. But if there is a CNS infection like meningitis, would you what is your take on that?
So already told that if infection is there, after ruling out infection, if you're not thinking of infection at all, then only I use this drug upfront.
A non-specific question again to Lokesh. So what is the role of that frisium that you give for febrile seizure? 3 days prophylactic frisium.
Frisium. So if you go by the literature evidence, there is no role. Even I have done a RCT in it. It is going to be probably published because it is revision has come in JAMA Pediatrics. RCT on febrile seizure, clobazam versus no clobazam. So
the problem is once a recommendation came, it's very difficult to remove that from our cortical system.
So that is what there is no recommendation. That is no recommendation as of now to give clobazam.
Correct.
But problem practical in India is like you see our patients comes from so many different parts, rural areas. So if they have breakthrough seizure, no medication is going on. What is their thought process is this doctor did not give any medication.
Okay.
And left us on our own. So at least clobazam prophylaxis for difficult patients, remote patients, where healthcare facilities are not available, at least prescribe them. So that is what I do. because evidence will say no, because 911 facility is there in the West and hospitals are in reach. They have their own home, safe homes. So,
Correct.
but our children can die also.
True. I think so. It's very regional based answer that you're given and very clearly. If you're in a metropolitan city, there is actually no role. But if you are in a limited setting where medication is not easily available, it's better to give them it. I agree. So over to Dr. Namit, sir. There are many neurosurgical patients in your unit. So what is the role of anti-seizure medication prophylaxis for patients who have congenital hydrocephalus or patient on VP shunt? What is the protocol in your unit?
So that is usually driven by the surgeons, but I think if someone has never had a seizure, but has had a neurosurgical procedure, which is almost the same as having a traumatic brain injury with a cortical injury. So if the cortex is breached, it's reasonable to give an antiepileptic.
And the one the same, the drug that you usually use, phenytoin versus Levera.
I think Levera is almost the default first line drug for just about everything these days.
Thank you, sir. Clear message. Dhirender, what is the target 3% sodium the Lokesh talked about? He told that we prefer as an intensivist to give 3% saline. Do you target a serum sodium level?
We target around 140 to 155, and we start with the infusion of 1.1 ml per kg per hour and target to achieve the sodium level of 145 to 150.
So, Lokesh, there's always a fight that we want to give an infusion, whereas sometimes some people want to give intermittent bolus. So, what is your take on that? You are an infusion person or you are an intermittent bolus person of 3% saline?
So bolus I only give when there is hyponatremia. Only give. If there is already the sodium is in the normal range 135 and we want a target of 145, I never use bolus in such setting. That is my because problem is even in working in a tertiary center like I've been in AIIMS Delhi PGI or AIIMS Jodhpur. Residents are there around the clock, but monitoring, because sometimes I have seen patients going in hypernatremia, iatrogenic hypernatremia. So bolus, if you are giving, so be very careful, monitor the child, because because if you give maintenance also after that, there is stringent monitoring is required. But my policy is to give bolus only when sodium is less than 135. I don't give bolus if it is beyond 135. I just give maintenance and infusion.
So, we agree with that also. Namit, sir, right, sir?
Right. Yeah. There's only one other condition. If you are, that's again very specific to ICUs. If you are on CRRT, and if it's a continuous dialysis which is going on, then infusion becomes useless. Then you have to give it as a bolus or increase the sodium in the dialysate fluid.
So this question is again to Lokesh. We have given a bolus of Levera. Right now it's 0 hours. When do you start the maintenance dose? At 12 hours, 24 hours, 6 hours?
12 hours.
12 hours. So we start it at 12 hours. So maximum dose you can all please see in the textbooks. How do we wean? If we have started people on 2 antiepileptic and a imidaz infusion, or how do we, which one to stop first?
For infusion or for antiepileptic drug?
For infusion, I think so. We cannot
I think because antiepileptic drug, we don't stop in the ICU setting at least, or even in ward before. So only after discharge, one by one, we go down. But infusion, if they are asking, so if you have achieved burst suppression or target, whatever your target was before starting infusion, seizure control, if EEG is not available, then decrease it by, I think 20% every 4 hours, we do go down.
Correct. We also follow the same policy. Mid-as infusion, how do you taper?
So we taper by 0.5 mg per kg per hour if the seizure is well controlled.
So we go up to 2 mg per kg per hour. So that's equivalent to 36 mic per kg per minute. We agree with what Lokesh is saying, that we go very high. We are actually mid-as pro unit. Namit sir, you believe in ketamine or midazolam or propofol?
So if benzodiazepine is working, we continue with the midazolam infusion, and usually we tend to look for another drug if we are breaching 20 micrograms. So if beyond 20, we'll start looking to add another drug.
Nowadays, many units have started ketamine infusion also, especially the adult units. They are very pro.
So we
We are
use a lot of
little,
ketamine as well. We use a lot of ketamine, especially when benzodiazepines are not having a good effect. Ketamine is a go-to drug.
So actually, ketamine is a very good option, as you must have seen in the pathophysiology. You know, it acts on NMDA receptors. So
Correct.
it is bound to work according to me also. We also use in refractory cases when it doesn't respond to midazolam infusion or even like intrathecal dexa if there is like eligibility for giving that. If they are not responding to that, we also go for ketamine infusion next. But not the first, we have not used it as first line before midazolam infusion till now.
so very specific question to Lokesh. In very simple words, when to consider IV methylprednisolone in status epilepticus? Very simple words.
So as I've already shown in the slide, if there is clear, if you are very clear that it is AESD related, like ITES related, A&E child has A&E and having status, AESD status, fires and NORS also. If you are concluded after 2 days that it is fires, nothing else, you have done investigation and ruled out infections, I give methylprednisolone. Or if I have not used intrathecal dexa.
Correct. Point taken. Very clear. And Livera, if you have given 60 mg per kg loading, what is the maintenance dose? 20 mg per kg per day?
So I use, if I've used 60 loading, then 30. If I've used 40, I have used for 20. That is my maintenance.
Okay. And any anti-epileptic protocol for, no, this is not status epilepticus. Okay. When to start ketogenic diet, and we'll close it from there.
So all these things, ketogenic diet and other forms are also available. These usually we think at the end of 5 to 7 days, refractory, lot of antiepileptics are already added, but not upfront if the etiology is not strongly metabolic. So if you are suspecting that it is a condition which ketogenic diet helps, definitely we use it upfront, obviously, but not, it is the last resort when everything is not working. We use usually in status management because it will take time to act. That is the problem with ketogenic diet. Ketogenic diet, because ketosis has to be achieved and it will not be achieved in 1 day, 2 day. It will achieve in at the end of the 1 week at least.
Okay. So one more question has come to Lokesh sir. If the patient has come with an unprovoked seizure, when would you start a AED?
Unprovoked seizure. So if it is a first unprovoked seizure, normal neurological examination, generalized seizure, there is, if you can sure you're not putting that in any of the syndrome, like where the child is bound to have seizure again, like JME, juvenile myoclonic epilepsy, I don't start antiepileptics in the first unprovoked generalized seizure, but any focal seizure, unprovoked, is definitely you have to start medication. And any generalized seizure also where you are sure that this is JME, by doing EEG, if you are suspecting, if you are having doubt, do an EEG, find out, okay, this is JME, you have to start antiepileptics. So if either a child who has a propensity to have seizure, according to you, either normal, abnormal neurological examination or anything like that. But if a normal neurologically child, generalized seizure, you can wait for the second seizure to happen, but you have to prescribe midazolam and all the instruction when they have seizure at home, what to do.
Perfect. I think so. We have taken 90% of the questions. Majority are of normal epilepsy, normal seizure. So over to Dharinder, you want to say anything about the lecture? Any doubts that you have? Anything you want to say for the students?
Sir, I would like to emphasize on the monitoring part during the ICUs thing. So the focus and the ONSD and uh, the TCD is now become the monitoring tool in PICU, and it is very easy to do in ICU setting. So we usually do a baseline TCD and ONSD in our patient, and it is very easy to do in the ventilated patient. So in TCD, we monitor the baseline MCA velocity and PI, the pulsatility index. And we usually do it 8 to 12 hourly, or if we give a hyperosmolar therapy, or there is change in neurological status. So
Agreed. So it's not only about EEG. It's also about the ONSD and
Yes.
TCD status depending on the etiology like liver failure, meningitis also. Lokesh, do you agree with that point?
Yes, actually, particularly in right now in my ICU, we don't have this facility. So maybe in future, when we have this facility, we will be using that also. I
Because
completely
I
agree.
know Dhirendra doesn't work without these monitoring devices. He is very particular about every round. What is this velocity? What is this number? So Namit sir, do you agree with this
So
ONSD
that is
and
the
TCD?
critical care domain primarily. I am sure
Correct,
that you. So that is what I have learned from. Maybe I will be using this all entity, this ONSD and TCD in my status management.
Namit sir, your take on that, sir?
No, no,
Focus.
absolutely. More numbers, the better. So in as many monitoring numbers that you can get, yeah, it's okay to have 20 numbers and then ignore 10 of them rather than not having those 20 numbers. So the more numbers, the better. Yeah.
So I'll thank you all. Ajay sir, are you there? Lalit sir?
Yes. So thank you very much and wishing everyone happy Diwali once again. Central IP elections are round the corner, starting from 22nd till 29th. So I request all of you to please exercise your voting right. We have two candidates from Delhi on national elections, Dr. Anurag Agarwal as Joint Secretary Liaison and Dr. Alok Bhandari as Treasurer. So we request all of you to please support them and wish you all a happy Diwali once again.
Thank
So
you.
thank
Thank
you,
you,
all the
Lokesh. Thank
respected
you, Namit.
faculty.
Thank you, sir. Thank you for the
Happy Diwali,
opportunity.
everyone.
Happy Diwali. Happy Diwali, sir.